Hi, my name is Thitikorn Nuamek. You can call me Pao. I'm from Thailand, so we all have nicknames because our real name is too difficult for us as well. I am from the Christie. I'm based in Manchester, the north of England. So I am a doctor. I'm not very technical, so I will be talking from the other side of how we implement PROMs and what is the outcome of that. And we kind of do a different approach to what was presented earlier. So basically we created, and like we use a better platform to develop that for an in-house EPROM system. So talking about the Christie, some of you may not know, it is the cancer center in the north of England, which is like one of the biggest in the country and maybe one of the biggest in the EU. So we treat quite a lot of patients, up to 60,000 patients, and because we are a cancer center, a lot of the activities is in the outpatient settings. So basically, for example, we have at least 500,000 patient contacts a year. We deliver chemotherapy at least 100,000 a year. Also the same for radiotherapy, and we treat, we look after quite a large region, which is like Greater Manchester and Cheshire, which is about 3.5 million people. But also because we're quite a big center, so we also receive referrals from any other regions in the north of England as well. So as you can imagine, cancer diagnosis changes people's lives, and it comes with unexpected challenges. It's not only just physical challenges, but it can also be emotional and practical challenges as well. And so it's very key in cancer practice, really for any practice, that patients and clinicians have to work together, have that conversation, and try to come up with a plan that not only treat cancer, but also support them along the way, especially when we give chemotherapy, immunotherapy, or radiotherapy, that we know that it can be quite an aggressive treatment. And one thing that that has quite mind-blowing, I think we all kind of know it anyway, but there was one study published in 2010 by a medical oncologist in the US. He basically asked 400 patients in 4,000 consecutive clinics to report their own symptoms. And he also compared what the patient says with what the clinician said. And they have found that actually clinicians tend to underestimate patient symptoms, and patients are likely to report symptoms much earlier and more frequently than clinicians. So this really highlights that we need to have patients reporting their own symptoms instead of having clinicians interpreting what patient says and documenting in the clinical notes. So that means over the last 10-20 years, there has been more and more initiatives trying to create some kind of tools that allows patients to report their own symptoms, and that is what we know as PROMs today. And so PROMs or EPROMs, they are essentially online questionnaire used to collect reports from patients about their own health. It can be their symptoms, functional status, quality of life, without interpretation by clinicians. And within the cancer world, we're quite lucky that we have quite a lot of evidence supporting the use of EPROMs. Over the last 10 years, we have at least 15-20 clinical trials comparing those receiving usual cancer care with those patients receiving usual cancer care with remote monitoring using EPROMs. And we have found that this group of patients using EPROMs have improved symptom control, improved quality of life, can tolerate their treatment much better, go to emergency rooms less frequently, admitted less frequently, and also have an increased survival rates. So in this case, why wouldn't we implement EPROMs in a routine setting? And also, quite groundbreaking, in 2022, right at the end there, we have the international guidelines by the European Society of Medical Oncology suggesting that we should be using EPROMs as well from the start of treatment until the end of life. So really, that's why within the cancer world, we're now using more and more PROMs, but it's use is still quite limited for a lot of reasons. At Christie, we're quite lucky that we receive quite a substantial fundings from 3 different sources: the Christie Charity, the University of Manchester, and Manchester Cancer Research Centre. And we managed to establish our own EPROM system called My Christie My Health, and this is how the system looked like. One thing that I would like to highlight is that the Christie, we develop our own patient portal, and we also have our own EPI as well. So we don't use, like for example, like EPIC, Sunrise, or anything like that. So we are quite different in the way that all these platforms are web link. They're not any kind of app. So this is how it looks like, just very similar to Open Outcome in the way that patient will receive EPROM by text message and email, and they use their surname, date of birth, postcode to log in, and once they log into that, they will receive a 6-digit authentication code to their messages, and they can use that to log into the form. So you can also scan that QR code as well to read our publications about the service. So really, how does it work? Just like what I said earlier, EPROM will be sent to patients via text message or emails, and they can complete that. Once it's been completed, it will be uploaded to our EHR in real time. And that can be reviewed or alerted to the clinicians, who can then support patient based on what patient has reported. And this EPROM can be sent at different time point, for example, before clinic appointments, or at like certain time point during their treatment pathway. So it really depends on different pathway of the patients. But in generally, a lot of patients will receive it before their clinic appointments. So I think this is the part that you might be interested in. So it has been 5 years now that we have implemented PROMs, and it's been a real roller coaster. At first, we use an external platform provider. That means basically we have a separate system from our EPR. And as you can see, we basically, with this about 2 years and a half, we managed to roll out to about 10 different services. We, just like any other hospital out there that like affected by COVID, so it has been the time that has slowed down. But even in 2021, where actually the activities at the Christie has been the most hectic time at the Christie, still we couldn't roll out as much as we wanted. One of the complaints that we have received from the clinicians is that they did not want to log into another system, because by doing that it basically increased their time. They have to do more clicks, and we couldn't really have that uptake. So when the contract was ending, we basically want something that we can build that EPROM within our own system. That's why we're trying to look for a system that we can build EPROMs quite quickly, and we're trying to build something that can be integrated within our EHR, and we have found better at the time. So since then, within a few months, we basically can review all the forms that we have built during those 2 years and a half. And following that, as you can see now, it actually like skyrocketing, and we have hit 60,000 questionnaire completed quite recently. And now I'm sure this month it will hit 70,000 very soon. Also, we have received the Greater Manchester Cancer Innovation Award in 2022 for what we do with the platform, and also we have published already actually 13 journal articles now, and the 28 abstract presented at different conferences. So it has been a real achievement for us. And talking about how it looks like, so this is how our electronic health record look like, and this is how EPROM basically are alongside those clinical notes. So if you see, like basically we have like the the structured form of, like, for example, the outpatient form, review form, whatever, but EPROM is basically alongside that. And actually, I only have one screenshot here, but this kind of show the timeline view of when patient completed a few times, how it looked for the clinician to be able to monitor the patient symptom over time. So that has really been a game changing, because like after we have done this, our completion rates actually jumped like quite a lot. And also we have 10 or 15 more teams basically reach out to us and wanted to use EPROMs. And now, this is where we are now. We have 37 different services using EPROMs, with at least about 10 more to come. As I said earlier, we have like about 66,000 forms from 23,000 patients. Our completion rate is not very high, it's about 44%. But one thing to highlight is that the Christie service is an opt-out service, so everyone will get one, even when they don't have a telephone or email, they will get an EPROMs. So we don't exclude anyone. That also means to support them, we also have a patient assistant to basically look through different clinic lists the next day and trying to reach out to patients or send reminders to patients to help them completing, or they can also contact our patient assistant as well. And because it's an opt-out service, it's quite different to other services out there that you have to add patient to the system. So that means like when you add patient to the system, there's always going to be a selection bias that you might, oh yeah, this patient might be able to use EPROM, so you add patient in. So in those services, you will see a completion rate of 80 or 90%. So I would like to highlight 3 different benefits of using EPROMs that we have found. So one is the benefits to the patient care. So one thing is that apart from what I have shown you earlier with the timeline user, you can actually monitor in real time how patients are doing. Another thing that we have received is actually that patient and clinician both give us a very highly positive feedback. So that is also a good sign. The second, or the benefit, is around service efficiency. So now because we can use EPROMs to remotely monitoring patients, so we can do a lot of cool things about it. For example, in the first one, we actually save time. So thinking about, like, in this service, we have a telephone follow-up for patients with breast cancer who on a treatment called HER2 therapy. They normally follow up monthly. They need to get their blood test done, and they need to get their echocardiogram done, which is the ultrasound of the heart, to make sure that there's no cardiotoxicity. But by doing that, if they have to come in to the clinic monthly, you can imagine that can be quite a service burden. So basically, apart from it is a telephone follow-up, we use EPROMs now. The team already know what's happening to the patient, so when they have a call with the patient, things are much quicker. They can go to the point and make the consultation more focused. So you actually have saved an average of 7.1 minutes. And also in certain cases, we also replace the telephone call with a virtual review of EPROMs. And like in these cases that we look at the group of patients, we can replace 90% of the calls with text messages. So that helps a lot with the service resources. The second one, also we improved the adherence by using EPROMs. Like with this service, again, a very similar one that relies on telephone follow-up. In this group of patients, they also need blood tests, and they need to measure their blood pressure quite regularly, and when they have the telephone call with the team, they should have them ready so the team can prescribe further medication for them. And what we have found after using EPROMs, we have found about 33% reduction of those appointments without blood pressure and without blood tests. So in this case, it really helps our team not having to have to chase the blood test again, go to contact patient again for different things that they need. And another useful thing that we now using is basically we use EPROM within the chemotherapy unit. What that means is that we know that patients, when they are unwell, they cannot receive chemotherapy. And if they, so that means if patient comes to the hospital unwell, we have to turn them away. But one thing that we can't turn them away is the medications. We already have prepped them, and we can't reuse them because it has been made for specific patients. So we lost thousands and thousands of pounds on that. Now we basically use EPROM to pre-assess patients who are suitable and not suitable before they come in to the chemotherapy. And if they're not suitable, basically our team will just call them and say, don't need to come, what kind of support you need, we'll support you, or we'll cancel your treatment, we save thousands of pounds. So that's another example of service efficiency benefit. And last thing I think we did talk about quite a bit is the use of research. We have, as I said, we have published already 13 journal articles and 828 abstracts. These are only some examples. We understand better the difference between cancer treatment, comparing patient groups. We can also predict the future of, like, if patient reporting something at this point, what will happen, what will likely happen to them in the future. One thing, just like what Kanthan has said earlier, is that EPROMs really form into the real world data research, and especially in cancer research, that normally in clinical trials, a lot of patients, including in the research, there are patients who are fit and well. But how about those patients that we see them in clinic who have dementia? What do we do with them? EPROMs can really help with that, and it feeds into our pragmatic trials that basically include all patients, and that include, like, especially those underrepresented in the clinical trials. And another thing is that it really helps us. I think it keeps the conversation going, and basically we have collaboration with a lot of teams out there around the country and the world. So that's what we are really, really proud of. Last thing, really, I would like to just end with having a good system to use, like having better team to help us manage, allow us to basically expand our service exponentially, and that really basically feed into this circle that patient can communicate to the clinicians and the clinicians can communicate back to the patients. And being able to use that, something that we built in-house, it really speeds that up, and it really doesn't, we don't have to click on new platform, do more clicks, so that wouldn't work. So that's all. Thank you.
Thank you, Carl. We can have a couple of minutes for questions for Carl. So, yes, Brian.
More of a comment, really, to both of you, is that I spoke to people, and sometimes PROMs is kind of like a tick box exercise. I spoke to somebody and they said, we just scan it in a bit of paper. How was your knee operation? It was fine, I feel better, and it's like that. But I think what both of you have done, and you need to come up with a new name for it, because it's not just PROMs, it's bordering on, virtual ward. How you missed a presentation yesterday from Dave, who was a cancer patient, and the question he asked when he was diagnosed was, what can I do to help me get through this? And this sort of thing is a real support mechanism for something like that, and engages the patient. So when it's just called PROMs or EPROMs from both of you, it just, I'm not just saying this because it's better, but it doesn't do justice to what you're actually doing here, because it goes beyond PROMs. Yeah. So it's more of a comment than a question. Yeah. Come up with a new name.
Yeah, so, we can't call it a different name, because there's so many nuances around PROMs, that it's not just a questionnaire, which I think a lot of companies think it is. There's a lot more behind it, because it's all born from research. There's sort of fine nuances, what's the difference in scores, there's all sorts of information that that's come out in the presentations we've done, but that's actually finding nuance. And there's actually the next level. So there's a computer adapted tests and things like that, where you, depending on your first question, you can then, the computer then decides the next question. So instead of doing 20 questions, you end up doing 2 or 3. So so there are sort of further along the lines, but I think we need to start somewhere. So start with the basics. And the other thing is around education. So telling patients that this is not just a generalised feedback form, this is part of your care. So when you see the patient, you go, I'm asking you this question because it's going to affect your outcome. So if you've got cancer, you can say, by answering this, you're going to have a better outcome than if you didn't. And then you do it. So it's that education. That's done by clinicians. It's not a health IT thing. It's done by me, by both of us. When we see the patient, say this is really important. And in my practice, that's what I say, and I get a high response rate because everyone fills it in. And I ask them, and I show them this is your score. And it's that benefit, it's that graph that you show the patient, and they see the benefits. They don't care if the score is 56 or 52. What does that mean, Doc? They want to be able to see, yes, I feel, yes, okay, yeah, that, I agree with that because it's getting better, or no, it's not getting better, So that there's an education piece around it. Why are you filling it? Why are you patients spending their time fill it in? And we want to reduce the friction. We don't want to give them multi-factor authentication, all the rest of it. They won't do it. You just need to give them something that's relatively secure, but they'll just get it done quickly, and they know the benefit of doing it. So.
Any more questions for Pal? I had one. What I'm really interested in both of your cases is, but I'll ask you first, Pal, is how you came to become passionate about this and how you plan to bring your colleagues on the journey with you. And feel free to jump in on that too afterwards, Kantan.
So I got this job 18 months ago, and I didn't really know much about PROMs. What I knew is that I was passionate about oncology and IT. So basically, I just found a job that kind of blends both things together, and I just applied for it. And one thing that I would like to say is when I applied for the job, I was asked to give a dissertation. And I was trying to think really hard where PROMs fit into the patient care. Basically, I thought of one analogy that we can compare clinicians just like a steak on a plate. A steak being a patient, and the vegetable being the clinicians, like just the healthy things, and the plate, which basically representing the organization that support this relationship. But EPROM is acting like a peppercorn sauce that kind of blend the food all together. And one thing we have to know, like, what sauce fit best, because you wouldn't use applesauce on your steak, for example. So it has to be tailored to your culture, your community, and I think it's really important to work with your team, work with clinician and patient, but not only just that. Within this job, I found I have to work with finance, operation, data team, IT, everyone else, and also people from within the NHS as well. It's very important because we should collaborate more, really.
Absolutely.
Yeah, so I mean, it's around patient-centred care because you're actually asking questions that matter to the patient, and you get that sort of consultation where patient talks to you, but the clinician interprets that. It depends on that interpretation. Where this is more objective, although it's subjective from the patient's point of view. That's what they're feeling, right? So these PROMs questionnaire are capturing their outcome, their pain, their function, independently, because you're not sort of suggesting things, or you're not translating what they're saying into documentation. You've got that from the patient themselves.
Yeah,
which is really important. So, and that's where shared decision making comes in around, how do we, how does the patient take control of their care, how they manage that, and I have a very personal thing around PROMs as well, because in orthopedics we like leaders in it, but then unfortunately my wife got cancer at 30. And we went through all the cycles of chemo, and then I read, six cycles normal, right? But then suddenly they said, well, we actually only need 3 because she's had a good response. But I was, what about, how do you know that, But actually, my wife turned around and goes, you're not the one that's getting the chemo, is it? So, because you've got to ask the patient, I can't do, if I only need to do 3, I don't need to do 6, right? Even though is there a survival benefit? That actually, I'd rather just stick with a 3, because if I do another 3, I'm going to be really, I feel awful. And that's where you can have the PROMs to kind of go, look, I've really suffered from this, and I don't think I can do any more cycles. And then you come halfway house. Well, what do you do? You can manage it that way rather than just doing, we're going to just stick with the standard thing and carry on if you see the need. So it's really getting the patient involved in their care. I think is the key.
Fantastic. Thank you both very much. A really good contribution.